Good morning and best wishes for all of us. Dear Honorable Dean of School of Pharmacy, International Medical University, Associate Professor Dr. Muhammad Zulkifli bin Mat Yusof, Dean of Faculty of Pharmacy, Pancasila University, Professor Dr. Apoteker Shili Kumala Magister Biomed, President of IPSA Saranya Balakrishnan, Chairwoman of SEMA FF-KMUP Felicia Evelyn, Chairwoman of BPM SEMA FF-KMUP Gina Agnia Hairunisa, Chief Committee of International Webinar Collaboration SEMA FF-KMUP and IPSA Goldimon Bernaldi, and all participants who have attended the International Webinar Collaboration SEMA FF-KMUP and IPSA today. Praise to the presence of God Almighty, because of His blessings and mercy, we can gather in this event in a very healthy and optimal condition. Ladies and gentlemen, my name is Andra Angelica. On behalf of the Committee of International Webinar Collaboration SEMA FF-KMUP and IPSA, would like to extend the warmest welcome. We appreciate you taking time off your busy schedule to join us today. So, ladies and gentlemen, before we start, I would like to read a few rules that must be obligated by the participants during this event. And as you can see on the screen, here are the rules of the International Webinar IPSA and SEMA FF-KMUP. Participants are allowed to join Zoom 10 minutes before the event starts at 8:20 Indonesian time for Indonesian participants and at 9:20 for Malaysian times for Malaysian participants. Participants re-registration starts at 8:30 until 8:45 Indonesian time for Indonesian participants and at 9:30 until 9:45 Malaysian times for Malaysian participants. Participants are not allowed to share webinar link that will be delivered by the committee through WhatsApp groups to the non-participants. Participants are expected to rename before joining Zoom with the following format: name_institution, as you can see on the screen. So once again, ladies and gentlemen, please make sure that you have already renamed yourself as the format given by the committee. The name used is the name when you are registering for this event. Participants will fill out the Google Form attendance list at the beginning and at the end of the event, which will be distributed by the committee in the WhatsApp group. The filling is only open for 15 minutes for Indonesia participants only in order to claim your certificate. So especially for Indonesian participants, I would like to remind you once again to fill out the registration form twice in the beginning and in the end of this event. And participants who want to ask questions or give some comments can give it through the Padlet link, which will be provided in the Zoom chat column in the format name_questions, using the polite language without containing any sensitive ethnicity, religion, race, and groups elements. And questions will be answered at the end of each session. And lastly, participants are not expected not to leave Zoom before the event ends. So that was the rules for the participants that must be followed by the participants during this event. And we do really hope that you can follow as the committee stated on the screen. So next, ladies and gentlemen, the webinar scheduled today will proceed as the following: the opening remarks, followed by the video presentation, and then going to be followed by the first material presentation, which is entitled Experience of Frontliners in Combating COVID-19, and followed by the second material presentation, COVID-19, Have We Won the Battle Yet? Followed by the games, and finally for the closing. So please make sure that you will stay with us until the very end of this event, because I'm also pretty sure there are going to be a lot of interesting activities which are we going to be doing together. So ladies and gentlemen, now let us hear a few words from the Dean of School of Pharmacy, International Medical University, Associate Professor Dr. Muhammad Zulkifli bin Mat Yusof. For Associate Professor Dr. Muhammad Zulkifli bin Mat Yusof, the screen is yours.
Thank you very much to dear MC, Miss Andrea Angelica. Can I confirm that my voice is loud and clear?
Yes, sir.
Thank you for the confirmation. Dear respected guests, Professor Dr. Apatikashili Kumara, Dean of School of Pharmacy, Pancasila University or Universitas Pancasila, Ms. Felicia Eflin, President of SEMA FF-KMUP, Ms. Saranya Balakrishnan, President of IPSA, Honorable speakers, Mr. Jody Wong from Pantai Hospital, Dr. Yati Sumiyati from School of Pharmacy, Pancasila University or Universitas Pancasila, organizing committees, ladies and gentlemen. Assalamualaikum, selamat pagi, salam sejahtera, and very good morning. On behalf of the School of Pharmacy, International Medical University, I would like to extend a warm welcome to everyone who joined us for this webinar today on a very lovely weekend morning. Dear students, colleagues, participants, as well as collaborating partners for this webinar from Pancasila University, Indonesia, and participants from Malaysia and overseas. The IMU School of Pharmacy, in collaboration with Senat Mahasiswa Fakultas Farmasi Universitas Pancasila, or short form SEMA FF-KMUP, is proud to present our first ever international webinar collaboration event addressing the global COVID-19 pandemic that has affected and taken the life of so many people now. COVID-19 is a term that we hear every day without fail now, and the battle is far from over yet. Numerous research papers are being published daily regarding the recent breakthroughs in vaccines and also the treatment of COVID-19 infections. Hence, the content and knowledge to be gained during today's webinar entitled COVID-19 Strategy to Find the Right Treatment is completely relevant and important to be understood by us as part of healthcare professionals and also fellow students in healthcare program. We know that many vaccines have undergone clinical trials, and some of them have made it into the market today. It is now very common for conversation to include the topic of COVID-19's vaccinations. It is very alarming to hear many members of the public sometimes spread misinformation regarding these vaccines, invoking fear in the minds of many regarding getting vaccinated. Hence, as healthcare professionals and also healthcare program students, it is our responsibility to educate ourselves with accurate information so that we can educate the others, especially the public. The treatment of COVID-19 in hospital settings have also evolved greatly since the start of this pandemic, as many trials have been conducted to determine the best treatment regimes. Hence, hopefully, after today's event, all of us will understand better the treatment regimes which are being used in the hospitals today. Ladies and gentlemen, pharmacists, doctors, nurses, and many other healthcare professionals all over the world are now working tirelessly to stop the spread of the coronavirus or this COVID-19 and to ensure people are treated with the best regimes available. I would like to take this opportunity to thank all our frontliners for their efforts during this difficult time. I would like to also thank the organizing committee of both the IMU Pharmacy Students Association, IPSA, and Senat Mahasiswa Fakultas Farmasi of Pancasila University for their great effort in putting this event together. An initiative like this is admirable, and education regarding COVID-19 is valuable in keeping up with the advances in its prophylaxis and also treatment. My appreciation goes to our very knowledgeable speakers, Mr. Jody Wong, who is also our IMU Bachelor of Pharmacy alumnus, and also Dr. Apotheker Yati Sumiyati, for sharing their expertise in their fields for this webinar. And to all guests and participants, thank you for your presence and support in making this event possible. I hope everyone here will take home as much knowledge as possible from this webinar and have a memorable learning experience. Knowledge has power. It controls access to opportunity and advancement. With that, I thank you.
Thank you so much, Associate Professor Dr. Muhammad Zulkifli bin Mat Yusuf, for your remarks. Next, ladies and gentlemen, we will continue to hear a few words from the chairwoman of SEMA FF-KMUP, Felicia Evelyn. For Ms. Evelyn, the screen is yours.
Thank you for MC. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya, and good morning everyone. I respect Professor Dr. Apotheker Silly Kumala, Magister Biomed, as the Dean of Faculty of Pharmacy at the Pancasila University. I respect the Dean of School of Pharmacy, International Medical University, which I respect Gina Akia Karunisa as the President of BPM FF-KMUP, which I respect Saranya as the President of IPSA, and for all participants at this international webinar event. Praise and thank God, because thanks to His grace, we can carry out this international webinar event. International webinar is the first international scale seminar held by SEMA FF-KMUP. I hope that with this international webinar event, it can introduce Pancasila University Faculty of Pharmacy to the whole world, establish friendship with health students around the world, and all participants can take good things that will be presented by the speaker. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh. Shalom, Om Santi, 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 Om Namo Buddhaya.
Thank you so much, Ms. Evelyn, for your remarks. And now, ladies and gentlemen, for the opening remarks and opening ceremony, we invite the Dean of Faculty of Pharmacy, Pancasila University, Professor Dr. Apotheker Silly Kumala, Magister Biomed. For Professor Dr. Apotheker Silly Kumala, Magister Biomed, the screen is yours.
Yes. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera, Om Swastiastu, Namo Buddhaya, dan salam kebajikan. Good morning, everyone. Praise and gratitude. We pray to our God. Through this blessing and guidance, we have opportunity to hold this international event. Welcome, Dean of International Medical University, Associate Professor Dr. Mo Zulkifli bin Mat Yusuf, Saranya Balakrishnan, a Chief of IMU Pharmacy Student Association, Vice Dean 3, Ibu Dr. Apotheker Nimade Sandi Utami MKes for Student Affairs, Felicia Evelyn, a Chief of Student Senat Pharmacy Faculty Pancasila University, Gina Agnia Khairunisa, a Chief of BPM Pharmacy Faculty Pancasila University, also advisor, lecturers, and all participants, and honorable speaker, Mr. Jody Wong and Dr. Apoteker Sumiati, MKes. I really appreciate SEMA FF-KMUP for the first seminar that was held on an international scale. Sorry, still can hear my voice?
Yes, Prof.
Okay, sorry. Yes. And this webinar talk about COVID-19 strategy to find the right treatment. Yeah, I think this topic is very interesting in the discussion at this webinar. I hope this webinar will give opportunity to all participants as well as knowledge and skill pharmacy students. And last but not least, I hope future collaboration and also this event can run smoothly and successfully. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you so much, Professor Dr. Apoteker Shili Kumala Magister Biomed, for the opening remarks and ceremony. And with this, ladies and gentlemen, we are officially opening the International Webinar Collaboration SEMA FF-KMUP and IPSA today. And next, ladies and gentlemen, we will proceed to the souvenir session. For the handover of souvenir, we would like to call upon Goldie Monbernaldi as the Chief Committee of International Webinar Collaboration SEMA FF-KMUP and IPSA to hand over the souvenirs. The first souvenir will be given to Professor Dr. Apoteker Shili Kumala Magister Biomed as the Dean of Faculty of Pharmacy, Pancasila University. We would like to call Professor Dr. Apoteker Shili Kumala Magister Biomed to the screen to receive the souvenir. Are the documentation team ready? We're gonna take a picture in 1, 2, 3. Thank you very much, Professor Dr. Apoteker Shili Kumala Magister Biomed. And the next souvenir will be given to Associate Professor Dr. Muhammad Zulkifli bin Mat Yusuf as the Dean of School of Pharmacy, International Medical University. We would like to call Associate Professor Dr. Muhammad Zulkifli bin Mat Yusuf to the screen to receive the souvenir. Documentation team ready in 1, 2, 3. Thank you very much once again, Associate Professor Dr. Muhammad Zulkifli bin Mat Yusuf. And the next souvenir will be given to Felicia Evelyn as the Chairwoman of SEMA FF-KMUP. We would like to call Ms. Evelyn to the screen to receive the souvenir. Documentation team ready in 1, 2, 3. Thank you very much, Ms. Evelyn. And the next souvenir will be given to Ginatnia Hairunisa as the Chairwoman of BPM FF-KMUP. For Ms. Gina, we would like to invite you to the screen to receive the souvenir. Okay, documentation team ready in 1, 2, 3. Thank you very much, Ms. Gina. And next souvenir will be given to Saranya Balakrishnan as the president of IPSA. We would like to invite Saranya to the screen to receive the souvenir. Documentation team ready? In 1, 2, 3. Thank you very much, Ms. Saranya. And ladies and gentlemen, after some brief remarks, we would like now to play a video presentation from SEMA FF-KMUP. And please enjoy.
What is Indonesian culture? Indonesian culture is all national cultures, local cultures, as well as cultures of foreign origins that existed in Indonesia before Indonesia's independence in 1945. Indonesian culture can also be interpreted that Indonesia has various ethnic groups and diverse cultures such as regional dances, traditional clothes, houses, music, martial arts, and crafts. Every culture is different for each province. What is displayed after this is only a small part of an Indonesian culture.
Wow, what a really interesting video. And so, ladies and gentlemen, that was a video presentation about Indonesian culture presented by SEMA FF-KMUP. We do really hope that it can introduce you to dozens and thousands of Indonesia's beauty. And now we have another video presentation by IPSA, which is so much interesting too. So please also enjoy.
Sumandap mantadi tanpa guling, baiknya raja hilau ikilang ruti.
Tinggi-tinggi gunung Kinabalu, tinggi lagi sayang sama kamu. Biru-biru ujung Kinabalu, tengok dari jauh hati saya rindu. Kinabalu dekat di kurasa, banyak sayang.
Wow, another interesting video by the IPSA, and I also hope that all the participants are also interested that Malaysia apparently has various cultures and arts too. And so, ladies and gentlemen, we have now come to the first material, which is entitled Experience of Frontliners in Combating COVID-19. With us now, we have Mr. Jody Wong, who is one of the medical team that fight in the front line during the pandemic. Before we start, I would like to remind the participants if there were any questions you would like to ask or comments to give during this session, you can submit your questions or comments through the Paddle link, which is going to be provided by the committee through the room chat. So once again, I'd like to make sure that you shouldn't put your questions or comments through the Q&A section, but on the Padlet link, which is given by the committee below. And right now, please kindly allow me to introduce you to our first speaker, Mr. Jody Wong.
Hi everyone. Can everyone hear me?
Yes.
Oh, can you guys hear me?
Yes, yes, we can hear you, Jody.
Okay, thank you. First of all, I'm Jordi. I'm ICU, CCU, HDU pharmacist from Pantai Hospital, Kuala Lumpur, from Malaysia. Nice to be here early morning on the Sunday to present you guys with clinical management of COVID-19 in Malaysia setting. But this will be my personal experience dealing with COVID patients, especially critically ill COVID patients, and hope that everyone will be enjoying will be learning something from this talk. I would like to apologize that because of my laptop situation, I can't be using my own laptop. So I need my help from IMU students to help me to move the slides. So this will be my slides. So I would be just talking a little bit about role of clinical pharmacists in COVID ICU and my personal experience in managing them. Okay, and next, thank you. So my COVID ICU actually is, I'm actually handling, there are actually 3 critical care wards available in Pantai Hospital. So there will be ICU, CCU, and HDU. And currently my ICU and HDU will be managing non-COVID patients. And the CCU is currently being converted to COVID ICU. So COVID ICU will be handling all the COVID, critically ill COVID patients. So my hospital is doing a hybrid setup, meaning we manage both COVID and non-COVID patients, but not together on the same ward, but at different ward setting. So in my COVID ICU currently is handling 4 patients. So because we only have 4 negative isolation room, so when the patient's being put inside the negative isolation room, they won't be spreading out the viruses. So they will be put it inside the room, and the airflow will be from outside the room, entering the room, rather than from the air inside going outside. So the admission criteria into my COVID ICU will be at least category 4 and above, and also if they require high flow nasal cannula or intubation. And also they need to discuss with my consultant intensivist. Next slide. And COVID ICU is never a one-man show. It's not like you just need a doctor and that doctor will handling all the issues and that's it. No, COVID ICU is made up of different healthcare professionals. We need to work together in order to make clinical management a success. So my COVID ICU leader right now is actually my intensivist. So what actually is an intensivist? Intensivist is actually a specialist who is usually is an anesthesiologist, but they subspecialize into intensive care. There is a difference between anesthesiologists and intensivists. Anesthesiologists that provide anesthesia, they do handle ventilation, but they are not as good as intensive care doctor, which is intensivist. Intensivists, they need to undergo another 3 years of such special training in intensive care setting. They need to learn about CRRT, your continuous renal replacement therapy, ventilation, septic shock, cardiogenic shock management. Is a very intensive care of specialist area, and this is intensivist. And also, co-leader will be by my respiratory doctor. Although there are 4 respiratory doctors in my hospital, but only 2 are currently active treating COVID patients. And there will be other physicians who are willing to help out, for example, cardiologists, nephrologists, if the patient has other comorbidities that we require their help. And also critical care trained nurses, especially with post-basic in critical care. They will be very beneficial because they know exactly what to do when the patient desaturate. They will immediately they will know what to do, put on oxygen mask, or if the patient blood pressure drop, they know what to do next. They will put on noradrenaline, and they know how to titrate all the vasopressor doses, even without a doctor's guiding them. This is a difference between critical care trained nurses and non-critical care trained nurses. And of course, clinical pharmacists, and there will be us, because you need to handling all the medication dosages. Nurses will ask you for medication dilution, and also if there is any dosage adjustment required, you can always provide the information. And if there is something that missing out in this patient, you can always do suggestion, because if you know that suggestion is going to benefit your patient, please suggest. Unless there is any contraindication, we can discuss with the consultant to see if there is any other alternative which can benefit the patient. And also clinical dietitian. Why is that important? For example, if the patient is intubated, you need to start rice tube feeding. If a patient, even though you do all the treatment right, all the nursing care right, all the doctor's job right, but without a proper nutrition supplementation for those COVID patients, the patient won't be doing well. Hence, we need a clinical dietitian on board to make sure they're giving them the good nutrition, good protein. Hence, we can wean off them from ventilation or wean off them from the oxygen support. And also the next very important people will be physiotherapists. They are often being forgotten, but they are very important backbone for COVID ICU, because COVID patients, as you know, when they go into category 4 and 5, they often need a lot of oxygen, they need ventilation, and there will be a lot of secretion inside their lungs. Although you know those patients are very infectious, but they still need to go inside, wear full PPE, and help those patients to remove those secretions to improve their lungs. Otherwise, their lungs won't be improved. That's why those physiotherapists are very, very important. And they also help us to prone the patient, because sometimes when the lungs is bad, you need to prone the patient to different positions, hence to improve the oxygenation of the patients. Next. So this is my current role in COVID ICU, and also my non-COVID ICU and HDU as well. So on the picture, the diagram on your left-hand side, so this will be my usual general role of mine in normal setting ICU and HDU. So we do pain management. We can discuss about anesthesia with my intensivists and other doctors. We also deal with TPN. We also deal with stress ulcer prophylaxis. For example, you need to start some pantoprazole or esomeprazole for stress ulcer prophylaxis if the patient is on high-dose steroid or is currently on anticoagulant, and you know that the patient could be having risk of stress ulcer. And DVT prophylaxis is very important. You need to do, we not to say audit, but to observe if each patient actually require DVT prophylaxis. For example, patient is bedridden, is intubated, not actually moving well, and patient is obese, actually the patient carry risk of DVT development. Hence, the patient might require DVT prophylaxis. And complex drug-drug interaction, because when in ICU setting, there will be too many infusion going on, and there will be too many drugs ongoing. Sometimes you just need to screen through the prescription to ensure to minimize the drug-drug interaction as possible. And if there is drug interaction, how to avoid them and how to minimize them and reduce the drug interaction to the minimum. And compatibility of infusion. This is very important. Imagine patient is having multiple infusion ongoing with adrenaline, no adrenaline, dobutamine, Nurenon, antibiotics, IV paracetamol, so many IV medication ongoing, but patient only has limited lines and limited lumen, then you need to give the medication. Hence, you need to ensure all the medication are compatible with each other before you actually can combine them and run together at the same line. Otherwise, if they're not compatible, they will crystallize and clog the lumen. Because as you know, lines are very precious in those patients. And if the lines are clogged, you need to change the line. And often changing the line, it requires a lot of effort for the doctors. And it will make the situation not as easy to handle for the nurses as well. If the lumen are blocked, the nurses need to know which lumen can't be used anymore, and there are lesser lumen to be used. And the next very important will be antimicrobial stewardship, which is whenever the patient doesn't need antibiotics, discontinue it. When you can downgrade the antibiotics, do downgrade the antibiotics to reduce the risk of having antibiotic resistance. While doing my routine work, now I need to combine with the COVID treatment management on top of my routine work in COVID ICU. So that will be what I'm going to share in a while. Next. So let's look at the clinical staging about COVID-19 diseases. So in Malaysia, I'm not sure about other countries, but in Malaysia, currently we are clinically staged COVID patients into 5 different stages. So when the patient is having PCR positive, for example, through the nasal swab, so you can subdivide in the patients, positive patient into 5 different stages. Are they symptomatic? If they are not symptom, they are not having fever, they don't have any cold and flu symptom, they're actually basically stage 1. If they are actually having symptom, for example, fever, but runny nose, cough, but with no X-ray changes, so there is no pneumonia, that is stage 2. If they are symptomatic, they will having fever, cough, cold and flu, runny noses, but there is X-ray changes, but they don't need oxygen, they are category 3. If they are having X-ray changes and they need oxygen support, there will be category 4. If those patients went into multi-organ failure, for example, they're suddenly having heart attack, their kidney function drops, their liver function got haywire, it involves other organs, the patient will become category 5. Next. So this is a very important slide to talk about, to relate to the treatment for COVID-19 patients. Why? You can see initially on stage 1, you can see early infection stage, the viral load is very high. You can see the viral load slowly coming down. So these are the stage. This is the stage where your antiviral works the best. Because the longer you wait to initiate your antiviral therapy for COVID, the virus already getting lesser, and your inflammatory response going out from stage 2 onwards, antiviral actually don't work that. Antiviral doesn't have much benefit anymore when that is in stage 2 and stage 3, but it's very beneficial in stage 1. From stage 2 and stage 3 onwards, steroids and your interleukin-6 inhibitors, they are your anti-inflammatory drugs, and they will come into play because your inflammation starts to going up and you need something to suppress the inflammation. For COVID-19 infection, the COVID virus is not scary. The COVID virus actually brings you the symptoms such as your cold and flu, things like that. But the worrisome part is when the virus phase is over, it induces the hyperinflammation stage that actually worsen your lungs, and it can increase the risk of thrombosis. And those are the scary part. And those are the things that we are currently handling. And where patient actually turns bad is because of the post-inflammatory response phase. And these are the phase that we are actually having troubles. It's not the virus itself, it's the virus-induced inflammation and the thrombosis. Next. So for general care, generally, all the COVID patients should actually receive symptomatic treatment if, for example, they are stage 1 and stage 1, they don't have any symptom. Okay, so category 2, if they're having cold and flu symptoms, they just need like antihistamines. If they're having fever, just paracetamol will do. We try to avoid NSAIDs in those kind of patients because NSAIDs, as you know, is a non-selective COX-1 and COX-2 inhibitors. So actually, NSAIDs will actually, in certain NSAIDs, for example, your diclofenac, meloxicam, they actually can increase the risk of getting thrombosis as well. As you know, COVID patients are already at risk of getting thrombosis. You don't want to use NSAIDs, which can actually aggravate the situation. Hence, we try to avoid NSAIDs. Naproxen, although it has least risk of causing thrombosis, but the bleeding risk is there. You don't want to use something that can induce bleeding. So we try to avoid all the NSAIDs and also selective COX-2 inhibitors. They are dangerous in COVID patients, so we try to generally avoid them. And also, for patients who actually require nebulizer, we try to avoid it because nebulizer is a vapor producing procedure. Whenever you put on nebulizer, actually when you nebulize the air into the patient, it can actually spread out the patient's saliva and also patient's secretion to surrounding, and which can cause the surrounding to be infectious. You don't want your nurses and the doctors to be exposed to those infectious agents. Hence, we avoid nebulizer for the first 14 days, because the first 14 days is usually the most infective stage. And hence, unless after 14 days, when patient is no longer that infectious, then you can consider nebulizer. Hence, we avoid nebulizer for the first 14 days and we use aero chamber. You can use the aero chamber with MDI directly, and it is a closed system. Then you can deliver your medication through MDI and via your aero chamber to the patient, and that is very safe. So it won't spread the saliva or secretion to the surrounding. And next one, we generally try to avoid antibiotics for all COVID patients unless the patient develop consolidation in the lungs. When the patient develop consolidation, it comes with the clinical judgment. It can be because consolidation sometimes can be caused by bacteria, it can be caused by viruses. So it's quite difficult to judge. Even lab result, although certain anti-inflammatory markers is low, but you cannot rule out bacterial infection. So at that point, you might need antibiotics. Otherwise, if there is no consolidation, you shouldn't start antibiotics because it can just unnecessarily inducing microbial resistance. Next slide. So for specific treatment, as I mentioned, category 1, there is no symptom. So we actually don't need any treatment at all. For category 2, because they're only having cold and flu or sometimes fever, symptomatic treatment we do. For category 3, actually, even though they are having pneumonia with lung changes, these are the guidelines from last time. I think that this is the guideline from Malaysia treatment guidelines, and the latest update for this guideline is actually last year September or October. So even though the patient, so our government actually suggests that when there is lung changes, but if the patient doesn't need oxygen, you shouldn't give any treatment unless the patient is actually having risk factors like age more than 50 years old with comorbid like heart disease, uncontrolled diabetic, end-stage renal failure, or if they're having warning signs such as increasing CRP or inflammatory markers, or if the patient is consistently fever. What else? If the patient is having increased D-dimer, lactate dehydrogenase, ferritin, these are the signs of increasing your inflammatory markers. Then you might be considered to start antiviral early. Next slide. So let's talk about antiviral. So our current available antiviral is in Malaysia is favipiravir. So favipiravir, we have a suggested loading dose and maintenance dose for our patient. So we're using 1,800 milligram BD for the first days, that is your loading dose, followed by 800 milligram twice a day for 4 days. So this total duration will be around 5 days. There are experts saying that you can use up to 10 days, but only for very, very ill patients. But from my understanding, starting the favipiravir as antiviral is just like we are starting oseltamivir, that is your Tamiflu for influenza. So if the patient coming early, when you start antiviral, it helps. But when the patient comes in late, like for example, day 14, day 15 with lung changes, that is already in the pulmonary phase or inflammation phase. The viral phase is already over. Antiviral is not that useful. It's not beneficial anymore. But to start this antiviral, you always need to be careful because it is a pregnancy X. It's a pregnancy category X medication, meaning it's actually contraindicated for pregnancy. And if the lady patients are pregnant, there are childbearing potential for ladies with childbearing age, you should always counsel them or ask them for consent. If they have any chances to be pregnant, then we might not want to start the favipiravir because it can cause more harm than benefits. And also, for your patient with CKD stage 4 and 5, we generally avoid this antiviral because it won't be cleared through your kidney because of the poor urine output. But if the patient is actually having dialysis, we actually warrant the use of favipiravir, but with a reduced dosing. But so far, currently, there is no suggested dosing for favipiravir in end-stage renal failure with dialysis. There is no suggested dosing, hence we just reduce the dose slightly as according to our experience. And it often causes liver function haywire, and that's dangerous because when your liver function got haywire, it start to complicate your treatment. So it's very dangerous. Okay, and another very important drug interaction with favipiravir is paracetamol. Because paracetamol, as you know, is metabolized through liver, and maximum you can use together with favipiravir is only 3 grams per day and not 4 grams. I know the maximum dose is 4 grams, but when your patient is receiving favipiravir, maximum for paracetamol is only 3 grams per day. Next slide. And before I initiate the topic on steroids and tocilizumab, which are your anti-inflammatory drugs for inflammatory phases, I would like to mention about ventilators, because if you don't understand the ventilators or the oxygen support in the setting, you can't understand whether the patient is it worsening or is it improving. Hence, you won't be in the same page with the consultant and the nurses, and you don't understand the situation. Hence, it will be very difficult for you to interact with the consultants, and you want to do suggestion. Next slide. So just some brief introduction to ventilation. So ventilation is a process of exchange of air between the lungs and the ambient air, meaning your surrounding air, and it's through a mechanical ventilator. So this patient is actually, these two pictures is actually shows you the picture, shows you the patient being intubated, being ventilated by the machine. So don't worry, I will brief you through next. Yeah, next slide. So there are 2 types of ventilation. One is non-invasive ventilation, meaning you see the patient having oxygen, like by the diagram on your left. That is the patient receiving oxygen through nasopron. And different oxygen delivery equipment shows you different amount of oxygen to be delivered. And invasive ventilation, you can see that on the picture on your right-hand side, there is an ETT tube connected to the patient's mouth and connected into the trachea to supply the oxygen and the pressure support from the machine. Next slide. So for non-invasive ventilation, it's a delivery of oxygen via face mask to the patient. So it achieves kind of comparative physiological benefits to the mechanical ventilation, But of course, it's not as good as mechanical ventilation. But we try to avoid mechanical ventilation in COVID patients because once they are intubated, it's very difficult to come out from ventilator. Hence, we usually try with non-invasive ventilation unless the patient really cannot afford, really cannot tolerate, then we need to intubate the patients. Next. Okay, there are different types of oxygen mask as you can see over here. So hopefully it will be clearer from this way. So for example, you can see the Nesapron. So it delivers oxygen 1 to 4 liter for your patient. Hence, you can always see, for example, if your patient develop increasing oxygen requirement, for example, today is Nesapron 3 liter. Tomorrow, the patient becomes face mask 8 liter, which is the diagram on the middle. Then you know that your patient is actually worsening and require higher amount of oxygen. Hence, you know you need to escalate your therapy. Otherwise, if you stop at your current therapy, the patient will go worse. Hence, you need to know when patient oxygen therapy, whether it's improving or actually coming down. And also, if the patient escalate to high flow mask, there will be higher amount of oxygen, 10 to 15 liter per minute. Hence, if patient is usually in high flow mask, the situation is not good at all, because if the patient, you still don't bend hard or hit hard at the stage of high flow mask, the patient might require the help for BiPAP, which is on your top right, or the patient might need high flow nasal cannula on your top right bottom. So this is your high flow nasal cannula. High flow nasal cannula is actually more beneficial for your patients in COVID because patient is having pneumonia, yet you just want to deliver your oxygen with a high amount, then you can deliver out to 40 to even 60 liters per minute for your patients. If you are using BiPAP for your patients, for your COVID patient, BiPAP is actually contraindicated in COVID because BiPAP use very, very high pressure and force the air into your lungs and out of your lungs. Imagine by using BiPAP, it can actually spread all the infectious agents to the surrounding. Hence, we don't use BiPAP in our setting. We just use maximum out to high flow nasal cannula. If the patient still cannot tolerate high flow nasal cannula, then we need to go into invasive ventilation, which is putting a tube through the ETT into the lungs via trachea. Next. So these are just now I mentioned about the non-invasive ventilation. So yeah, I discussed about this. Next. So for BiPAP, when do we actually consider BiPAP? Like BiPAP just now, the big face mask that actually can supply oxygen and also the pressure. We only consider BiPAP if the patient has comorbid of COPD or the patient actually have heart failure with acute pulmonary edema inside the lungs. Then you need BiPAP machine. But we only use BiPAP machine just like nebulizer. Only after 14 days, when the patient are no longer infectious, then you use BiPAP machine for the patients. Next. So when the patient can't tolerate BiPAP or can't tolerate high flow nasal cannula, the patient still desaturate, meaning their SpO2 drops, their PO2 drops despite on maximum support from BiPAP and also high flow nasal cannula, you need to ventilate them. Once COVID patients are being ventilated, their outcome is usually quite bad. Hence, when they're being ventilated, for example, the picture on your left-hand side, for example, this one patient is being ventilated. Usually, patient will be taking a while to come out from ventilation because your ETT tube can only be connected for around 14 days. If longer than 14 days, actually it increases the risk of ventilator-acquired pneumonia. You don't want that to happen. So if you know that your patient can't be ventilated for too long, then you need to do tracheostomy early, which is shown on the right. So you remove the ETT tube from the mouth, from the trachea, and hence you connect through the trachea side. You connect here to here into the trachea side to supply the oxygen and the pressure from the machine via the tracheostomy. And it carries lesser risk to cause ventilator-acquired pneumonia. These are the cases usually when you suspect your patient required ventilation more than 14 days, then you put them on tracheostomy. Otherwise, you keep them for too long with the ETT tube in the mouth, and that is not good. Next slide. Now, you already know that the simple introduction about the ventilation. Now, we can talk about steroid treatment, because otherwise, if you don't understand about ventilation at all, you can't discuss treatment of steroids and your tocilizumab with the consultants. If you have no idea about all the ventilation or airway support, you basically can't understand what are they talking about. Is the patient worsen or is the patient improve? You don't understand. Yeah. So this one is from NICE guideline. So from NICE guideline, they suggest that when your patient develop pneumonia with the oxygen support, and they require oxygen to support them, then you only start steroid, meaning they will be in entering category 4, because their category 4 is pneumonia who requires oxygen support. Then you start steroid therapy. From NICE guideline, they actually suggest to use dexamethasone. If dexamethasone is not available or contraindicated, then you use hydrocortisone or prednisolone. Otherwise, they use dexamethasone and continue the treatment for 10 days. There are a lot of trials why they actually suggest to use dexamethasone. For example, recovery trial, RECOVERY, recovery trial, they actually use dexamethasone 6 milligram daily for up to 10 days. Because they say when you use dexamethasone in patients with category 4 and above, meaning they need oxygen, and it actually shows that it reduces the mortality in those patients. And dexamethasone has shown that there is no benefit in patients who doesn't require oxygen. And next slide. So the diagram on the left-hand side is the guideline from Malaysia. Diagram from the left-hand side is the guideline from Malaysia. So this is what we currently practice. So we use dexamethasone as the first line for patients who require oxygen. But dosing-wise, we don't really follow 6 milligram daily, that's specific, because guideline is always just a guide. You should always adjust your dose according to your patient. For example, you have a 40 kilo patient and there is a 100 kilo patient. And 40 kilo patient, they require only 2 liter oxygen, but 100 kilo patient, they're currently in high flow mask. You can't be dosing them the same way, because otherwise your treatment is going to fail. You need to dose them accordingly or individualize your dosing. For example, 40 kilo patient, you can start them with 6 to 8 milligram of dexamethasone once a day. But for 100 kilo patient who is currently on the high flow mask, they are actually on the high oxygen support, they might need higher dose. Sometimes we even, from there's one hospital university called UMMC. They are currently practicing high dose dexamethasone, even up to 20 milligram daily. And that's what we do sometimes. When you dose them high, the patient won't progress so badly. So dexamethasone 6 milligram daily is just a guide. You can always adjust the dosing according to your patient's weight and according to your patient's lung conditions. And if the patient doesn't tolerate, if the patient worsens despite on dexamethasone, then you escalate to methylprednisolone. Methylprednisolone, the dosing recommendation from Malaysia is actually quite low, 0.5 to 1 milligram per kilo. And we actually use it initially, but it doesn't work for us. We just feel that this dosing doesn't work that well. So we actually start to use higher doses. We use 250 to 500 milligram per day for around 3 to 5 days. Usually we keep it for 3 days if possible, because you don't want to use high potency steroid for too long. Because by giving methylprednisolone for too long, the patient will have uncontrolled glycemia, will be having hyperglycemia, uncontrolled diabetic control. Also, you will prompt the patient to risk of infection. For example, fungal infection. Now in India, you can see they use methylprednisolone very often. They actually induces mycomucosis. And also in our setting, we also see Candida pneumonia and Candida UTI. So in HUKM, there is another university hospital in UK. It's called Hospital UKM. That is my place that I study my master. And my ICU pharmacist, Sifu over there told me that when you use methylprednisolone over there, they actually start to see fungemia, meaning fungus in the blood. And hence it complicates the treatment. Hence, you need to use methylprednisolone in a more rational way that you know when to start, but you also know when to taper down to dexamethasone. You don't overuse your methylprednisolone for too long. Otherwise, you can just induce infection in your patient. So for NICE guideline, the suggested dosing will be either IV or oral dexamethasone. It's more or less the same, but they don't recommend methylprednisolone. So different guidelines have different way of telling you things, but you just need to interpret them carefully because each guideline is just a guide. You can't be using the guide for all your patients. So you need to individualize your treatment. Yeah, next. So this is another beautiful drug. It's called interleukin-6 inhibitor, namely tocilizumab. So why will interleukin-6 inhibitor come into the picture? Because when there is an increased level of interleukin-6, they always mention that there will be immune dysregulation. And always if the patients don't do well with the ventilation, they go into ARDS, which stands for your acute respiratory distress syndrome, they could be having high level of interleukin-6. Hence, you don't want it. And you want to use you might want to use tocilizumab to reduce the interleukin-6 level and to reduce the inflammation response. And another reason why you use tocilizumab is, although you can always escalate your therapy from dexamethasone to methylprednisolone, but methylprednisolone takes time to work. While waiting the methylprednisolone to work, you should add on tocilizumab early. The moment you add on tocilizumab, it adds fast, and you can repeat out to three doses. If the first dose doesn't work, you repeat the second doses 12 hours later. Hence, you can reduce the oxygen requirement and prevent the patient go into mechanical ventilation. That's the benefit of using tocilizumab. Otherwise, if you just rely on methylprednisolone alone, it won't work so well. Methylprednisolone, it takes time to work. The moment it works, the patient already ventilated. So it causes your treatment to be difficult, and it delays the recovery for the patient from the ventilation. Next slide. And also when to give and when not to give. For example, just like I already mentioned, you know that the patient desaturate or oxygen requirement is increasing despite on methylprednisolone. And while waiting methylprednisolone to work, please start tocilizumab early. Don't wait. And also there are, of course, contraindication to start tocilizumab. For example, we don't have evidence in young patient yet. And if the patient has a liver impairment, you need to be careful. And if patient is actually a neutropenia, you need to be careful. Otherwise, tocilizumab can actually worsen the infection. And intestinal perforation also. I'm not too sure why. I think you guys can read more about the intestinal perforation. Next. And these are the current proposed regimen in my hospital. We use tocilizumab 8 milligram per kilo per dose. So maximum you can go up to 800 milligram, and you can give maximum out to 3 doses with between 8 to 12 hours apart from each other. And these are the proposed dose regimen from my hospital. Next slide. And also, other than, remember just now I mentioned about the inflammatory stage due to the COVID viruses. And also the next thing you need to worry is the risk of having thromboembolism, because COVID patients tend to, after the viral phase, they will be at higher risk of thrombosis, to get pulmonary embolism. Some patients present with ischemic stroke. Some patients present with heart attack. That's why when you admitted your patient, always start them on anticoagulation early. Otherwise, they will be having risk of thrombosis, and it complicates your treatment. And patients don't do well if they develop pulmonary embolism, because the mortality rate is very high. Next slide. So these are the current dose regimen. You can, for low risk patient, we give them 0.5 milligram per kilo per day. But for high risk patient, you always can consider higher dose with enoxaparin. We give them even up to BD dosing. In my setting, I try to avoid unfractionated heparin because unfractionated heparin, as you know, it can induce heparin-induced thrombocytopenia, and you don't want that. Hence, I try to generally avoid heparin. So I would just reduce the dose of enoxaparin for patient with kidney problem. For example, next slide. Next slide. Yep. So over here you can see. So for patient with actually how do you know that actually your patient is having high risk to get thrombosis? You can have a look at the critically ill DVT prophylaxis part. Whenever your patient keep desaturating, but when there is no obvious changes in the from the chest X-ray, there is no worsening of chest X-ray, but patient keep desaturating, you need to suspect patient could be having pulmonary embolism, and hence you need to double out your enoxaparin doses. Or your D-dimer is a test for coagulation. So if this test, a D-dimer actually shows more than 5,000, or there is a rapid jump of D-dimer from 1,000 to 3,000, for example, rapid increase in D-dimer, you need to use higher dosing of enoxaparin. Otherwise, when your patient develop pulmonary embolism, it will be too difficult to treat and too complicated to treat. And now, next slide. So for this part, it will be very beneficial because sometimes we're having problem to dose enoxaparin for different kind of patient. For example, if patient is actually having end-stage renal failure, and if the body weight is normal, and if the patient is actually obese patient. So you can have a look over here. For patient with CKD stage 4 or 5, with 18.5 to 40 of BMI, you give them 30 milligram daily of enoxaparin. But if the body weight is more than 40, we suggest to give them only 40 milligram daily for low-risk COVID patient. But you will also ask, how about high-risk patient? Then you can see for the next slide. For the next slide, for this one, when the patient is actually having high risk to get thromboembolism in the kidney impairment patient, you can actually give them slightly higher, even up to 0.8 milligram per kilo per day. But of course, you can always increase the dose, but remember that end-stage renal failure patient itself is a risk for bleeding. If your patient is elderly, your patient is patient is anorexia, not very a bit fragile, and patient is also on antiplatelet, the patient actually carry risk of bleeding. By simply increase the dose of enoxaparin, we actually cause them to bleed instead. That's why sometimes you need to be careful not to over anticoagulate them. So that's why we do discuss with my consultant before we initiate any anticoagulation. Next slide. So for some of the post-COVID patient, we actually do give them prophylaxis. For example, rivaroxaban for them to bring home. That's why rivaroxaban is your direct factor 10 inhibitor. We give them home because they are actually high-risk patient to get thromboembolism even after discharge from hospital. So for example, they're intubated, obese patient, don't ambulate, don't usually move around, you need to give them rivaroxaban, or you can actually give them enoxaparin to bring home. So they will be less likely to develop thromboembolism. Next slide. So just some quick sharing of the case study. So this is case number 1. The patient is actually end-stage renal failure needing dialysis 3 times a week. So it's under the care of geriatrician. Then now, because this patient admitted to ED with high-grade fever, white blood cell is okay, platelet is okay, hemoglobin 9.9, but the requirement for hemoglobin usually is 10 to 12 for end-stage renal failure patient, so not too bad. But CRP is elevated, 130. So CRP is your inflammatory markers. Procalcitonin is 8, which actually tells you that the patient is having bacterial infection. And for the end-stage renal failure patient, you need to cover for CRBSI. That is your catheter-related bloodstream infection. But patient at the same time is having COVID test positive. So these are the tests that I show you below. Is patient is having COVID positive also. Next. So after this, then my the geriatrician referred this case to my intensivist. Then at night time, I'm always on call. That's why my intensivist give me a call to ask me the choice of antibiotics to covering CRBSI. Initially, I want to suggest cefazolin and ceftazidime to cover CRBSI, but she prefers something just one agent. So at the end, we discuss and we use pictazole. And pictazole is a piperacillin tazobactam. We use only 4.5 gram BD because patient is end-stage renal failure. And also we start IV dexamethasone early. And because patient is currently already on face mask, so this patient is already minimal category 4. Because end-stage renal failure, the patient comes with this premorbid, so I won't categorize this patient as 5 yet. On day 2, the CRP continues to rise to 170. So patient is slightly in the worsening side. Can be delayed in responding, but can also means worsening. So we're not too sure yet. D-dimer is 2,400. So at the same time, we escalate the dexamethasone to methylprednisolone early. And we start the favipiravir. On the first day, initially, we don't want to start because we thought that it's already over the viral phase. But we discussed about it, and maybe there will be the patient still having viral load is still there, so we just start lah. But we use a reduced dose 600 milligram BD rather than 800 milligram BD because this patient is end-stage renal failure. Then we also initiate parenterovide because parenterovide contains vitamin C, which has an antioxidant effect and which might be helpful for COVID patients. And you also start pantoprazole, which do give stress ulcer prophylaxis early because patient is end-stage renal failure, and we're going to give the patient enoxaparin because patient's D-dimer is quite high, end-stage renal failure, COVID category 4, patient is at risk of thrombosis. That's why we start enoxaparin early, but we use low dose, 20 milligram daily. And patient is slightly breathless. That's why we started MDI, but we didn't give Combivan. We give budesonide and formoterol to puff BD via the aero chamber to bronchodilate the lungs, basically. Next slide. So after a few days, blood culture actually shows there is no growth. Procalcitonin coming down from 8 to 5.6. So patient actually is responding to the treatment of your antibiotics. So we continue the antibiotics. And also CRP coming down the moment we escalate to methylprednisolone. And hence we actually want to taper the methylprednisolone. On the second day, we taper down to 250. And on the third day, we downgrade back to the IV dexamethasone, 20 milligram daily, because patient actually improving in terms of CRP and the oxygen requirement actually coming down. And hence we off the oxygen, but at the same time, we found out there is some organizing pneumonia development in the chest X-ray, and hence we refer to resp doctor and we transfer out the patient on third day, I think. Yeah, this patient didn't stay long in my ICU. I think third day or fourth day we transfer out already. So you can have a look on the case number 2. I try to be fast because they say I'm over time. So case number 2, this patient, you see, I'm actually sharing the two the patient with similar comorbid. This one is also end-stage renal failure patient, 3 times, need dialysis 3 times per week. But this patient underwent hematopoietic stem cell transplant for his underlying lymphoma. So currently under the care of hematologist and my nephrologist. So he referred this case to my intensivist early because this patient present at ED with high-grade fever, and that is the day 1 of symptom. White blood cell is slightly elevated, platelet is very low, only 26, and CRP is 159, procalcitonin is 57. This patient is in sepsis, basically. and hence you need to start antibiotic because it's just post-stem cell transplant, and you need very broad spectrum antibiotic for this patient because you just need to cover broadly first. And COVID is also positive. And this patient, next slide. Then hematologist also call me at night time for that patient. So we do blood culture and we start IV meropenem because post-stem cell transplant, you need to cover for ESBL and Pseudomonas. That's why we start early. And hence, we also cover the patient with MRSA covering. We start vancomycin. And we also give IV dexamethasone early and start antiviral early as well. Because the patient already on 2 liter oxygen with saturation between 98 to 100%. On day 2, white blood cell slightly elevated, platelet is still low, although D-dimer is elevated, but we didn't start enoxaparin because the platelet is too low, is lower than 50 is. As long as platelet less than 50, we don't recommend to start anticoagulation because it might actually increase the risk of bleeding. And microlab actually informed that it's gram-negative bacilli in the blood. Because it's gram-negative bacilli, we discontinue vancomycin. So this is where antimicrobial stewardship comes into place. We discontinue vancomycin. We continue IV meropenem because we know it's gram-negative bacilli. Vancomycin is for your gram-positive. We continue IV dexa. We continue the antiviral. Next slide. So this patient also has low immunoglobulin level. So after discuss with my hematologist, we actually give a dose of IVIG. So IVIG is your intravenous immunoglobulin that might benefit your patient with hypogammaglobulinemia because it has been shown that whenever patient is having infection, active infection, giving them a dose of IVIG may benefit them. Next slide. And once blood culture comes back with Pseudomonas, actually I discuss with my hematologist if we want to de-escalate the antibiotic from meropenem to cefepime or ceftazidime. But he said that because patient is currently on steroid and post-transplant patient, the patient could be having risk of hospital-acquired infection. That's why we didn't de-escalate. And hence, patient is actually comfortable with Nesapron 2 liter. Hence, we decide to transfer out this patient to general ward. Next slide. However, 5 to 6 days later, patient's chest X-ray worsened. Patient chest X-ray worsened and required more oxygen from 2 liter to 3 liter. And doctors can hear crepitation at both sides of the lungs. And also CT scan of the lungs shows bilateral ground glass opacity. Later, I can show you the CT scan. We still didn't start the enoxaparin yet because I remember the platelet is still very low, less than 50. Hence, we escalate and CRP actually coming up. From 15th of May is 59, then CRP go up to 109 on day 8. And hence, we discuss with my hematologist and intensivist, we transfer back the patient back to CCU, back to my COVID ICU, and we escalate the IV dexa to IV methylprednisolone. And we start tocilizumab early because we know methylprednisolone takes time to work. We start tocilizumab early by using 8 milligram per kilo for this patient. Next slide. And these are the CT chest X-ray for this CT chest for this patient. You can see at the top left, this is the basal of the basal lungs of the patient. You can see some of the organizing pneumonia at the basal of the lungs, but there is no obvious consolidation. So I doubt the patient is having bacterial infection in the lungs. Patient is having bacterial infection in the blood, but not in the lungs. So these are due to the inflammatory process of COVID infection. So you can see there are some organizing pneumonia at the basal and also ground glass picture. Ground glass picture, I think, is more obvious on the right-hand side of top picture. Right-hand side top picture, yes. Below this marker, you can see the patient is more like a glass. You break the glass, then it shows like breaking out. So we call ground glass picture. And that's what we say ground glass picture. So on the middle zone, that will be on your bottom left. Yes, this is your middle zone. There are still white patches around and very obvious on the right side. So left side is slightly better. And you can see the fourth picture on the right. And there is not much infection, not much changes on the upper zone. So meaning this patient is having COVID inflammatory pulmonary phase and having the ground glass picture from the bottom to the mid zone, but upper zone is fairly clear. Next slide. So since the patient is comfortable with oxygen of 3 liter, we continue IV methylprednisolone, and we key in view one to taper down the steroid to dexamethasone, and we didn't give any tocilizumab on this day. Next slide. And on day 10, patient's oxygen requirement actually go up to 5 liters per minute. Although there is no changes in the chest X-ray, chest X-ray changes, but oxygen requirement increasing because patient desaturation. So at this point, actually, you need to consider 2 things. One is because although chest X-ray no changes, we don't want to downgrade your steroid so early. So we maintain IV methylprednisolone. Second, we start tocilizumab. We give another dose of tocilizumab because we think that the patients, you need to treat the patient and don't treat the radiologically and don't treat the patient through lab values. That's why we give another dose of tocilizumab and we maintain methylprednisolone for this patient. But the next thing you need to consider is this patient could be having pulmonary embolism because we haven't started enoxaparin so far, and oxygen requirements suddenly go up with no chest X-ray changes. Hence, you actually need to consider pulmonary embolism. But my hematologist say so far still not too bad unless the patient keep desaturating despite after giving methylpred and tocilizumab, then we will consider enoxaparin for this patient. Yeah. So now we just need to know that each patient you need to treat them differently. And each patient, you might not know which kind of direction the patient will be going. So you need to be careful when you are dealing with critically ill COVID patients. Yeah. Next slide. So these are the chest X-ray you can see. From this one is from the 12th of May. Initially, not much. Lungs is fairly clear. Then only with slight fluffiness on the peripheries of the lungs, then that is usually how COVID pneumonia comes into the picture. COVID pneumonia usually comes from the peripherals and slowly affect into the lungs. It will start from the peripherals. So you can have a look on the 16th of May, which is on your left-hand side. So this is on your 16th of May. You can start, the markers become slightly obvious on the bottom part, but upper part still quite clear. And you can see on the 18th of May, 18th of May, you can see the chest X-ray white patches become more. So there is actually progression of chest X-ray. And patient actually turns back radiologically. And also oxygen requirement going up. Hence, my hematologist decide to transfer back the patient from general ward back to COVID ICU. And hence, we escalate the dexamethasone to methylprednisolone and we give a dose of tocilizumab. And the chest X-ray on 21st, there is not much changes. So actually, you should suspect pulmonary embolism, although because oxygen requirement going up with not much chest X-ray changes, it should actually consider pulmonary embolism for this patient. So you should actually do CTPA to rule out pulmonary embolism at this point of time. Yeah, next slide. Oh, so I'm done with the slides. Now I just want to show that, you see, these are my cute 2 little daughters. My daughters on the left-hand side is Dr. Shamala, my intensivist. And the right-hand side daughter is my hematologist, Dato Shankar. He always like to add Superman pose. So funny, like him. So these are my daughters. Next slide. They're wearing full PPE. And these are my nurses, and how they're handling the patient. And you can see for the picture on your left-hand side, this machine is actually the high-flow nasal cannula machine. And these are the machines that used to supply oxygen for your patient. And you can see it is connected to the IV drip. And that IV drip is your sterile water for injection. The reason why you need to connect with an IV drip with your high-flow nasal cannula is because high-flow nasal cannula can provide up to 40 to 60 liters of oxygen for your patient. Imagine that is a dry air. your patient will feel triggered and will feel irritated, want to cough more. So by connecting the sterile water for injection to this machine, it can humidify the air and cause the air to be humidified and supply the humidified oxygen for your patient. So your patient will feel much more comfortable with the high flow oxygen. And you can look at the picture and hence also why the sterile water injection now is worldwide out of stock also, because they are needing for a lot of high flow nasal cannula usage. You can see the picture on my right hand side. These are my two ICU nurses. They are wearing PPE for each other. Otherwise, they need to make sure they wear the PPE in the correct way. Otherwise, if they don't wear in the correct way, they might get infected themselves, and which is not worth it because we need them a lot. Next slide. And this is my physiotherapists on my left. Physiotherapists, as I mentioned, they are very, very important. When the COVID patients are having a lot of secretion, they can't cough out. They are the people who actually help them to bring out the phlegm, bring out the secretion. Otherwise, it can actually worsen their situation and causing hospital-acquired pneumonia. And you can look at the picture on your right-hand side, and that is Atembra, which is your tocilizumab. So can you imagine the bottle with the red cap? The dose is 400 milligram. This bottle is actually 4,000 Malaysia ringgit. I don't know how much is Indonesian ringgit. You can just convert and have a look. And the green cap is actually 80 milligram, and it is actually 800 Malaysian ringgit. So this patient required 560 milligram. Hence, this dosing is around 5,600 Malaysian ringgit. And this is just one dose. Imagine sometimes when your patient doesn't do well after one dose, you need to repeat the second dose and even the third dose. So can you imagine the cost to be treated in the hospital? Yeah, next slide. So basically, that's it from my slide. And the person standing beside me is Dr. Shamala, my intensivist, the only intensivist in my hospital. I work very closely and work very well with her. And because of her, our COVID patients are managed to be safe most of the times. So thank you so much for all your attention. I'm so sorry that I overtime a lot. Hopefully you guys learn something from my slides and learn something from my talk. Thank you.
Wow, thank you so much, Mr. Jody, for your amazing presentation. And there we can see the introduction of the roles in the front lines of COVID-19 until the medical therapy and management of COVID-19 patients, along with some brief discussions through the cases, which makes the presentation so much more interesting to learn. And I hope the participants could also get a whole new insights about this frontliner's role in COVID-19 management. And I guess our participants are also already very eager to deliver their questions regarding to the topics which has been presented. Before we start our discussion, Mr. Jordi, how would you like to conduct the discussion?
I'm okay. You can just tell me the questions or things like that. Yeah.
Oh, okay, here.
Yeah.
Maybe we can just start from the first left on the left one, yeah.
On the left one.
Yep,
Regarding steroid therapy, why it is escalate to methylprednisolone, as dexamethasone is more potent than methylprednisolone. So actually that is, you can always dose dexamethasone and methylprednisolone. They are actually, when you dose them the same, they are actually equal potency. You can actually look at how you convert dexamethasone and methylprednisolone. For example, dexamethasone 20 milligram is almost equivalent to IV methylpred 125 milligram. Hence, if you dose methylprednisolone 250, it's actually equivalent to IV Dexa 40 milligram. So you can't really say Dexa is more potent than methylprednisolone because each steroid has a equipotency dosing conversion. And the reason why we escalate to methylprednisolone is methylprednisolone, you can go even higher dosing, such as 500 or even 1 gram. And that is the dosing that IV Dexa can't achieve, because we don't have any evidence to use IV Dexa more than 20 milligram daily. Hence, we escalate to methylprednisolone, and it can bring the more steroid effect. Hence, you can't say dexamethasone is more potent because as long as you use higher dose of methylprednisolone, it becomes more potent than dexa. But when you use IV dexa 20 and IV methylpred 125, they are the same potency. If you guys understand what am I trying to say. And the reason why we escalate to methylprednisolone is, yeah, as I mentioned, you can go higher dose and it can bring more benefits. It can bring more benefits lah. But always remember, keep your methylprednisolone not too prolonged use. 3 to 5 days is a good duration. Once you feel your methylpred already brings the effect that you want, taper down to dexa as fast or as soon as possible. Otherwise, you can induce a lot of side effects, such as your fungemia, bacteremia, and also uncontrolled glycemia and things like that. Yeah. Next question. About the treatment of plasma convalescent therapy, is it an effective way as a lifesaver for COVID patient in critical condition? There are a lot of evidence that convalescent plasma is still undergo trials. So we currently in Malaysia setting, we don't practice convalescent plasma as I know of, because it requires the blood donation from post-COVID patient. That's one. I think that's not too difficult to get nowadays because of so many cases now. So, but the benefits, whether is it there, is still unsure. You can always read out the NICE guideline, whether they're always, I think NICE and WHO do mention about each individual drug dose, each individual treatment, whether are there benefit for the patient. For us, we don't practice using convalescent plasma because the evidence is not there yet. Unless we have a more valid evidence to prove that we can actually use convalescent plasma, then we can consider. Otherwise, it still doesn't bring, we still don't get the trials that actually shows that it's so beneficial for critically ill patient. But when you have tried all the treatment therapy, maybe convalescent, when you try all the therapy and patient still doesn't improve, maybe giving convalescent plasma will be a treatment option. But nowadays still don't have a very valid treatment, valid evidence yet. Yeah. Next question. Just now I read about, does fungemia can be seen in all corticosteroid or only methylprednisolone? So far what we've seen, dexamethasone doesn't seem to be bringing so much of bacterial infection or fungus infection, but methylprednisolone, yes. Because when you use methylprednisolone if you use more than the duration, or you use too high dose for when you use too high dose for prolonged duration, yes, you will put the patient into too immunocompromised state. Then the patient will be very easily colonized with fungus and at risk of fungus and fungemia also. But dexamethasone, so far we haven't seen, but doesn't mean it doesn't cause fungemia. As long as you are a patient on steroid, they are immunocompromised, and if your ICU is having risk factor for candida infection, if your ICU is always famous with fungal infection, then you always be careful. And you can always use candida scoring for your patient. Candida score, whether the patient is in sepsis, is a patient on TPN, does the patient needs had intra-abdominal surgery done, things like that. You can, if the patient has any fungal colonization, then you can see whether the patients, how high is the risk to get a candida infection. Then you can consider to start antifungal early for prophylaxis. Wait. Hi, Mr. Jody. Thank you so much for the interesting sharing. Thank you for listening. About the tocilizumab, if it works at the first dose, it means the second dose won't be necessary, right? Yes. If the patient respond at your first dose of tocilizumab, you won't need the second dose. As long as, for example, now the patient is on face mask 10 liter. The moment you start tocilizumab, we can wean off to Nesepron 2 or 3 liter. Then you don't need to repeat anymore because patient is responding very, very well. Unless there is no improvement within 12 hours or patient is progressing in the need, there's from face mask become high flow mask within the 12 hours, then please give the next dose 12 hours later. And maximum you can give up to 3 dosing. But because tocilizumab nowadays is having worldwide shortage. So certain government hospital in Malaysia actually reserve only one dose of tocilizumab for each patient. If the patient gone back, given one dose didn't improve, they won't bother to give another dose because they need to reserve the use of tocilizumab. Otherwise, they will run out of tocilizumab, and other patients can't be saved. Yeah. So next question: steroid done, tocilizumab done, plasma convalescent done, pangemia done. Okay, can you explain more on the dosage adjustment of favipiravir in CKD who is getting dialysis? So there is no proper dosing suggested yet. There is no proper dosing suggested yet for CKD patient, and it is contraindicated in CKD EGFR less than 30 with no dialysis. But if the patient is having dialysis, because favipiravir is dialysable, hence we willing to give those favipiravir but at a reduced dosing at around 600 milligram BD. But there is so far no evidence yet or proper guideline to teach us how to dose. Certain government setting teach us you can actually just use the same dose, but I found it 600 BD is just as good as 800 in end-stage renal failure with dialysis patient. Yep. About the new variant is known to be unknown. Is there any way to indicate if we were infected or not? This part is not about the clinical management, so I won't be answering this part lah. Maybe you can pass this question to the next speaker. Yeah. Yeah. I think that's it from the question. Good. Yeah.
All right, thank you very much.
Thank you so
once
much.
again. Yeah, Mr. Jordi, for answering the questions and allowing us to understand more about this frontliners in the pandemic. And now we would like to invite Goldimon Bernaldi as the Chief Committee of International Webinar Collaboration, SEMA FF-KMUP and IPSA, to hand out the certificate of appreciation for Mr. Jordi.
Thank you.
Yep, the documentation team ready. And 1, 2, 3. Thank you very much, Mr. Jordi and Mr. Goldie. And
thank you so
it
much
looks
for
like-
inviting.
Yep, it looks like Mr. Jordi needs to leave the room immediately. So I am inviting all of the panelists to turn on the camera now because we are going to take the documentation again together before Mr. Jordi has to go. Are we all set? Okay, documentation team ready. In 3, 2, 1. Yep. Thank you very much once again, Mr. Jordi, for the
Thank you so
sharing.
much. Thank you so much for inviting. Thank you, and hope you guys have a wonderful Sunday. Thank you. Bye bye.
Bye bye. And so, ladies and gentlemen, to set the ball rolling, let's move on to the second material, which is entitled COVID-19, Have We Won the Battle Yet? And now with us, we have Dr. Apoteker Yati Sumiati, Magister Kesehatan, as one of our beloved lecturer from the Faculty of Pharmacy, Pancasila University. So before we start, please kindly allow me to introduce you just for a brief moment of our speaker. So Dr. Apoteker Yati Sumiati, Magister Kesehatan, is one of our lecturer in the Faculty of Pharmacy, Pancasila University, and she apparently expertises in a few fields in the pharmaceutical field, and she is currently responsible in the operation and finance manager of QLab, the Faculty of Pharmacy, Pancasila University, from 2017 until right now. And she has also done a lot of researches, and she has joined a lot of organization in pharmaceutical field. So without any further, now ladies and gentlemen, please welcome Dr. Apoteker Yati Sumiati, Magister Kesehatan. For Dr. Apoteker Yati Sumiati, Magister Kesehatan, the screen is yours.
Okay, thank you. Bismillahirrahmanirrahim. Thank you, Andrea, for nice introducing. Yeah, I want to confirm whether my voice clear enough.
Yep, it is.
Ah, okay. Then I'd like to share my screen right now. Okay. Oke, Assalamualaikum warahmatullahi wabarakatuh. Good morning everyone. Selamat pagi, salam sejahtera. Alhamdulillah, great to meet you all. First of all, I'd like to thanks to SEMA, Fakultas Senat Mahasiswa Fakultas Farmasi dan Keluarga Besar Mahasiswa UP, and also for IPSA, International Medical University Pharmaceutical Students Association, for giving me such a great opportunity for sharing the knowledge. And my topic will be COVID-19. Have we won the battle yet? And I'm sure that you all can answer this question clearly. Yeah. Before we go to the talk, once again, I'd like to introduce myself because in Indonesia, tak kenal maka tak sayang. Okay, currently, like Andrea introduction, that I'm a lecturer from Faculty of Pharmacy from Universitas Pancasila. And my experience as central laboratory manager before giving me much knowledge how the clinical trials and especially for the vaccine development were done very strictly. The teams working hard for years, decades, yeah. I remember that the time we were studying about the dengue fever vaccine, and it's very, very hard works, yeah. So the message is once the vaccine has launched, there are many clinical evidence and also consideration behind. So you just don't worry to support the vaccine, just vaccination, because it's already research before. And as a good citizens, just follow the governments. Yeah, and we know that our government are fighting for COVID-19, provide the best vaccine, and we must support it. Yeah, this is my first message. Okay, according to the term of reference that has been given by the committee, the discussion of our talk is about, first part is about immune system and viruses, and we will answer the question how our body works against them. And the second, we will talk about vaccine and sera, which one is more effective. I think Mr. Jody has already given an explanation, so I will briefly talk about this. And the third is about COVID-19 vaccine, yeah, picking the best one. And the fourth is about vaccine as the ultimate weapon to take down the pandemic. Do we really immune after vaccination? Of course, not 100%. Yeah, we know that the protocol, yeah, must follow strictly. And the last one, we will talk about the COVID-19 vaccine, especially for elderly and comorbids. Okay, before we move to the first part, these are the picture of cases COVID-19 in ASEAN, and Indonesia has been in the first place. Yeah, almost 2 million people infected by the COVID-19. You know that. Okay, you know that it is a very we must focus on the cases, yeah. And this is the mortality rate is quite high, 2.8%. Okay, and we know that the pandemic of the novel coronavirus SARS-CoV-2 has been posing a great threat in the world in many aspects. Yeah, we know that Mr. Jody has already talked about the therapeutic strategy, and then we will talk about the vaccination is still in progress, and we still fight for the disease. Yeah, and we need to learn to the life logics of SARS-CoV-2 and the interaction of the virus with the host. Yeah, to to understand the fundamentally important in the fight against the SARS-CoV-2. So this is the picture of the viruses. Yeah, you see that. Sorry. Okay, you see that the viruses has protein. Okay, I will laser point that. Has many protein, yeah. From the outer perspective, there is spike protein or S protein, and the membrane and the envelope, and also nucleocapsid. And we know that the COVID-19 is an RNA viral virus, yeah, that easily to mutate. And this picture shows how the virus replicates itself into millions and start to destroy the body. The spike protein, yeah, in molecular study, you will learn that the S domain will bind with the ACE2 receptor, angiotensin converting enzyme 2 receptor that mostly distribute at the lung, yeah, but in other tissues also, yeah, this binding will allow the protein to enter the host cell. Next, the virus will uncoat it itself and release the genetical material RNA, and then the material RNA will transcript itself, yeah, into million, and then furthermore, it will translate into protein, and then will be assembly into a new viruses and release to find healthy cells to be the place for the next replication process. And these are the picture of the pathogenesis and the clinical manifestation of COVID-19. Yeah, after binding, yeah, in RBD or receptor binding domain and the receptors, ACE2 receptors in the lung and in the other tissues such as liver, kidney, and the blood vessels, yeah, it will initiate the immune system, the patient immune system, yeah, both the innate and the adaptive immune system, and then develop such a pro-inflammatory situation, inflammatory situation, and making a condition called cytokine storm. Yeah, and the cytokine storm will uncontrolled, dysregulate, and infect and lead to the damage of the systemic level of the organ. So as taught by Mr. Jordi, that the figure illustrates escalating phases of COVID-19 disease progression with associated symptoms and the clinical signs and also potential therapy. Yeah, and it I think Mr. Jordi has already explained. Yeah, the longer virus stay in the body, the highest risk for the patient to get the severity. Yeah, and we will cut the process with the vaccination. Yeah, when the vaccinated people infected with the virus, we hope they only experience only in the first stage. Yeah, which means that it is a very mild condition. Okay, then first part of our discussion is about vaccine and sera, and we will answer the immunology aspect and mechanism of immune system, how our body works against them. Okay, before further discussion, I'd like to remind you all, maybe you remind the immunology lecture, yeah, that our immune system is divided into groups, the innate immune system and the adaptive immune systems, yeah, both cellular and molecular or humoral, yeah, and these are this component of the immune system, yeah, the leukocytes, macrophage or monocytes, neutrophil, yeah, eosinophil, basophil or mast cell, and also the natural killer cell and the dendritic cells. Yeah, you maybe you have already heard about the cells. that play important roles in the innate immune system, which give a very rapid response for the to against the pathogen. And the second term is the adaptive immune system, yeah, which the component is cell B and cell T, T cell and B cell, or I often call it BT, yeah, B cell and T cell. And also for the humoral component, it is an antibody or immunoglobulin, yeah. You know that there are 5 forms of immunoglobulin: IgG, IgM, IgA, yeah, IgE, dan IgD. Yeah, and for the COVID-19 aspect, for the vaccine aspect, we will talk about the IgG and IgM, where is the antibody that in the blood flow. Okay, and aligned with our immune system, we also have two types of immunity: innate immunity and adaptive immunity. We will talk longer about the acquired or adaptive immunity. Yeah, this immunity is divided into 2 terms: the active one and the passive one. The active immunity, our active immunity is develops in response of infection or vaccination. Yeah. So if you have the immunity, adaptive immunity from natural, mean you are infected by COVID-19, then you will have the adaptive, active, natural immunity. But when you have the adaptive immunity, but from artificial form, or I mean this term is from vaccination. Now this is the active one, yeah, and then the passive one is from natural antibody can be transferred from mother to the baby through the breast milk, yeah, or through the breast milk. And then the artificial one is what we call about the sera, yeah, or plasma convalescence therapy is the passive immunity that maybe Mr. Jody thought that Malaysia don't perform that platform, yeah, but in Indonesia it is used the plasma convalescence therapy. So this is the difference between the vaccine and sera. Vaccine is artificial active immunity, and the sera is artificial passive immunity. Of course, the two function of the both platform is different. Yeah, active is for prevention. Yeah, the passive is given which the disease is already present. Yeah, the patient is already infected and needs some help, needs some antibody. Yeah, needs some help antibody from survivor to against the COVID-19 virus. Okay, I hope you all familiar with the terminology what we will talk about. The immunization, yeah, providing specific protection against pathogen, and the vaccination, yeah, means introduction of vaccine in individual, which means it's active immunization, and the vaccine itself is a preparat, yeah, containing a pathogen. The purpose of the vaccine is to stimulate the antibody production and formation of the immune cells memory. Yeah, this is the most important. The antibody production and the immune memory cells, yeah, without causing the disease. So it is wrong information whether the vaccine can give you the disease. Yeah, the vaccine will give you a protection without causing the disease. And this is the general mechanism, yeah, how the vaccine can interfere our immune system for producing the antibody. Yeah, so you know that when one person shot by the vaccine, yeah, we know before that the vaccine is a pathogen, yeah, means introducing the virus, artificial or inactivated virus. We will talk about the vaccine platform later. into the body, and the pathogen will activate our immune system, our immune component, our innate component. Yeah, there are some cells called APC, antigen presenting cells, yeah, including the macrophage or the dendritic cells or B cell itself, yeah. And the APC will introduce the pathogen into the B cells, yeah. B cell will respond and will make a differentiation, yeah, to become a plasma cell, and the plasma cell will secrete the receptor called antibody, yeah. And this antibody, we know that will have the neutralizing properties, yeah. This antibody can catch up the viruses and make the immune system more response. Okay. Besides, this process will increase the memory B cells. This is the illustration. Yeah, this illustration is quite simple. Yeah, that the antibody, yeah, the B cells will differentiate, become a plasma cell and secrete the antibodies. Yeah, the antibodies will capture the pathogen, the same pathogen. Yeah, so the vaccine is very specific. Vaccine COVID-19 just for COVID-19. Yeah, very specific. So because the memory cells is only remind the same pathogen that will be introduced by the vaccine. Yeah. The opsonization process, we call it opsonization, yeah, catch the bacteria or the viruses will easily to identify by the macrophage, yeah. So the immune response will have the fastest response. Okay, maybe it's about the immunology aspect, yeah. So I will remind the function of the B cells and the T cell as our adaptive immune system, that B cells will produce the antibody which will neutralize the virus, which will coordinate with the phagocytes, yeah, and it will activate the complement. And also, other vaccine has the strongest response. Yeah, besides the humoral adaptive immune system, they will induce the cellular, the T cell, helper T cell, and also cytotoxic T cells. Yeah, as the effector, yeah, effector cells that will kill the viruses directly. This is what mRNA from the Pfizer or Moderna will work. Okay, then the second subtopic is about immune system and viruses. We will pick the best one. Yeah, we will also once again mention the difference between vaccine and plasma convalescence treatment. Before talking about vaccine, these are the survey about vaccination that performed by our MOH, Minister of Health, and then together with Indonesian technical advisory groups on immunization and the WHO and the UNICEF. Yeah, 74% Indonesian people has already known about the government plan about vaccination, and thanks God, yeah, most of them would like, yeah, to receive the vaccine. Yeah, yeah, and we know that small number, about 7.6, that do not want to be vaccinated by the government. And then this is the current status, that the target of Indonesian people for the vaccination is more than 180 million people. Yeah, and until this time, we have already about 14 million people. So it will take more hard work, yeah, to vaccinate all the Indonesian people to get free from the COVID-19. And in one slide, yeah, I take this slide from the immunology.org. Yeah, I'd like to explain about the vaccine. Yeah, that the vaccine will train your immune system using a harmless form of the virus. Yeah, and then the purpose is to activate the adaptive immune response, both humoral or antibody and cellular. Yeah, B cell and T cell. Yeah, the most important is to build the memory. So it will give you the long-term immunity. Yeah, once you will experience with the viruses, you have already the weapon to struggle with the disease. Yeah, so you don't have to experience with the severity stages. And this is the schematic representation of convalescent plasma component, yeah, and its mechanism of action. That this is quite different with the vaccine platform. Yeah, we know that the plasma convalescence is derived from the survivor. Yeah, and then it is needed much treatment to get the antibody to extract the antibody. Yeah, because we know that in plasma there are many substances, yeah, such as proteins, and then many cytokines, and then clotting factor. Yeah, so the important part of the plasma convalescence is the antibody. Yeah, and we know that the evidence for the using of the plasma convalescent is still in progress. Yeah, so I understand why Malaysia don't use that platform of therapeutic. Yeah, but in Indonesia it's still used. Yeah, because the antibodies, yeah, will have the neutralizing properties, both IgG or IgM. Yeah, that will neutralize the viruses and help the patient for recovery from the disease. And this is the I think this is the bottleneck, yeah, that we need technology to perform the right antibody for the treatment. Yeah, some procedures such as blood separation and then antibody quantification need to be performed before introduced to the patient. Yeah, because the antibody not all the survivor has quantitatively or qualitatively needed antibody. So it is need to be investigated further for the use of the convalescence plasma. And then currently the plasma convalescence therapy is used as option or alternative therapy for eligible patient. I mean the patient with the moderate to severe stages. Yeah. So if you are a survivor from COVID-19, you can contribute to the battle, just become a donor. Okay. The third our discussion is about the vaccine itself. Yeah, we know that it is a lot of kind of vaccine. Yeah, we need to difference between Sinovac vaccine, Pfizer, Moderna, or AstraZeneca in the aspect of material efficacy and effectivity. This slide is I get this slide from CDC, yeah, from the Central Disease Controlling, that the vaccine of COVID-19 has three main platforms. The first platform is a whole viruses, yeah. So the whole SARS-CoV-2 virus is used as the pathogen that introduced into the vaccine. And the second platform is the only part of the viruses. Example, the spike protein. Yeah, just take the spike protein and build in the vaccine and introduce to the patient. And the third one is the genetic material. We know that COVID-19 is an RNA material, genetic. Yeah. And the whole microbes approach, can be used with the inactivated vaccine, that virus, or I think this one is not applied, the viral vector vaccine, we know that AstraZeneca that now been performed in Indonesia using the viral vector vaccine. And the other one is the subunit approach, only use the very specific parts, of a virus, to make immune response from the patient. And the third one is the genetic material. This is the procedure. I'm sorry, it's still in bahasa. This is the procedure of development of the vaccine. So in normal condition, it takes years, even decades for the development. Start with the basic research and then the preclinical studies and the clinical studies, phase 1, 2, and 3. And then we need an approval and also followed by the pharmacovigilance study actually. But in COVID-19, the process is cut. I mean, the cut is about the time, not the procedure, why it is happen, because we have already the adequate technology with a lot of experience before, from the study before, that will speed up the process, before it takes decades. Now it takes only years, to produce a vaccine. Okay, but please be note that all the process must be performed. I mean, the clinical stages cannot be cut, and the current vaccine has followed the rules. So don't worry about the safety of the vaccine, And these are the vaccine platform that built by many pharmaceutical industries around the world. We know that Sanofi and Inovio is developed the DNA-based vaccine, by their technology, and the RNA vaccine, is performed by Pfizer and Moderna, and the Sinovac, that has been used by Indonesian people is an inactivated vaccine, and maybe later we will use Sinopharm, Sinopharm, the same as Sinovac, is an inactivated vaccine. And the AstraZeneca that has been performed by Indonesian government, is a viral vector vaccine, and then the subunit vaccine is developed by the Novavax. Okay, these are I modified a video. I don't know if this can open or not. Okay. Okay. Okay, this video is this picture will tell you about the efficacy of the vaccine. We see a very number, of the vaccine, the efficacy, and the Pfizer is 95%, the best one, and we see the GNG or Johnson and Johnson vaccine is only 66%, WHO have the number 50%, to give the permission, so even though it's only 66%, it's already more than 50%. And then this number is derived from the clinical trials. We know that in the clinical trials, there are two groups, in placebo and the vaccinated groups. And in each group will experience with the disease, and the efficacy will be calculated by this this formulation, the risk of unvaccinated, and the risk of vaccinated, and we will follow these rules, and we will this is if 85% 85 patient in placebo and 85 patient in vaccine groups, yeah, the equal number of the people experience the disease, the efficacy will be 0%. But if the 170 people, yeah, it is just an example number, yeah, experience with the disease in only in placebo groups, it will give 100% efficacy. It is I mean the example for the 98%, yeah, efficacy, meaning that 95% 95% people less likely to develop COVID-19, yeah, a COVID-19 infection when he is or she is vaccination, yeah, doing the vaccination. So the number is yeah, related to the incidence of the disease, yeah, but maybe we will have a new horizon that different number is derived from different circumstances between clinical trials, yeah. So actually this this video is derived from the GNG vaccination, yeah. So the Moderna and Pfizer, why have the highest efficacy? Because the clinical trials is performed in this area, yeah, while the COVID-19 is quite middle. But the GNG, yeah, GNG clinical trial is performed in the highest percentage of the COVID-19, yeah. So the numbers is just a number. I will give you an horizon that the most important is this, yeah. We know this is the broad spectrum of the infection of the COVID-19, yeah. No infection start from the ideal vaccination purpose, that is no infection, but if they are experienced in with infection, there are no symptoms, moderate symptoms, severe and hospitalized, yeah, and the vaccine will reduce the risk of death, the risk of hospitalized, and the risk of the severe symptoms, yeah. So if you are infected by the COVID-19 and you have already vaccination, yeah, you hopefully you will keep alive and keep you out from the hospitalized and the severe experience, and hopefully later the pandemic will be end. Okay, next I will share you about our governments, yeah. Indonesian government has already decided kinds of vaccine that will be used in Indonesian vaccination program. They are from Bio Farma, our industries, yeah, pharmaceutical industries, and the AstraZeneca, and then the Sinopharm, also Sinovac, and Moderna and Pfizer, yeah. Currently, we are experienced from the Sinovac and the AstraZeneca. Yeah, for your information that in Universitas Pancasila, around 500 lecturers has been shot twice with Sinovac in April and May, yeah, and 600 educational staff received first shot of AstraZeneca vaccine. And in reality, we found that the side effect from AstraZeneca, yeah, such as fever, headache, nausea, and vomiting were higher compared with Sinovac vaccine, yeah. And also in Indonesia, there's an issue about the batch number 547, yeah, is quite strong, that makes some our educational staff hesitate for the second shot, yeah. But thanks God that our governments, has already ensured the safety of the vaccine. The efficacy of the vaccine is more higher than the side effect. Okay, that is about the vaccine. Then the next question is about, do we really immune after vaccination? Yeah. Okay, I will remind you about the importance of the vaccination. That the vaccine will protective immunity. And then immunological memory that will give a great effect from you for the protection of COVID-19. And the vaccine cheap, free of charge, currently free of charge. The government has already paid it for us. And the cost effective and easily administered and adaptable to mass vaccination. And also the vaccine are safe. Are safe, and the most important is stimulate both cell-mediated and humoral immune system. And the function of the vaccination is to build the herd immunity, herd immunity. And then actually, immunity that provided by the COVID-19 may be transient. We will develop neutralizing antibody, but the quantity of the quality is vary between individuals, and it needs to be evaluated. And then in high herd immunity, this is the picture of herd immunity. That will be the purpose of our vaccination programs. We knew that the immune people, that if most people in Indonesia or in Malaysia get vaccinated, can act like a buffer for COVID-19 transmission. So the virus is contained. The spread will be handled by the vaccination programs. And next, the question is, how about the mutation? Does the vaccine still have efficacy if the virus is mutated? And we know that as RNA virus is easily to mutation. We knew that many variants, B117, B1351, and then so on. Many kind. And in India, the new cases, were found double mutation, found in India. And will the vaccine still have an efficacy for the new variants? And this is what we can tell you about. So actually we don't have to worry about the new variant. Because yes, we knew that the virus always changes itself to survive from the human treatment. That mutation make the virus inherently better at infecting people and then escape from neutralizing antibodies. But studies suggest that the current authorized vaccine work on the circulating variant. That the vaccine is still okay to be used in current situation. And the last one, we will discuss about the elderly and also the comorbid. Why there are some restriction and why the double shot is have to wait until 28 days. Okay, this is the data that show the infection fatality ratio based on age. You can see that the elderly give higher number than the young one. Okay, so the hypothetic is related to a condition called, the condition called, we call it immunosenescence theory. Jadi, so the immunosenescence theory is a critical factor that makes the elderly more susceptible to infectious disease. That in elderly, there are a condition called inflammaging. Inflammaging is a state of chronic low-grade inflammatory in elderly associated with increases the incidence of inflammatory disease because the decline in the immune system functionality as people ages. Yeah. And older people tends to develop more severe form of respiratory disease than the young one. So the elderly have the first priority in vaccination in Indonesia. And the comorbids, how about the comorbid? Yeah, do they, the people with underlying medical conditions such as cancer, yeah, chronic kidney disease or lung disease or condition related to the heart, yeah, the heart or other condition, yeah, has beneficial from the vaccination, yeah. And thanks God, yeah, CDC confirmed that COVID-19 vaccine may be administered to most people with this underlying medical condition. But you have to talk to healthcare provider for advice first, yeah, before taking the vaccine, and then inform the vaccination provider about the allergy and the health condition. These are the example, yeah, the example for the AstraZeneca, yeah, that we know that yes, side effect of the AstraZeneca vaccine blood clots, yeah, it's shown in several study, yeah. That is the condition related to the platform itself, the AstraZeneca using adenoviruses, yeah, as the vector to get the vaccine, yeah. And then the adenovirus is can be activated the platelet, and then body will respond by producing antibodies against the platelet factor 4, and then it will coordinate with blood clotting condition. And ethylene diamine tetraacetate, yeah, as a part of the stabilizer and binding agent that is used in the vaccine, open the junction between cells, yeah, and likely allow the giant complex to enter the blood circulation and make some clotting. Okay. Okay, I think this will be the last one, yeah. Why we need to talk? Why we need double shot for the protection, yeah. Why it takes time until 28 days for second shot or for Sinovac, or 2 months for AstraZeneca, or only 3 weeks, yeah, for mRNA coronavirus vaccine, yeah. It has been researched before, and we know that the booster process will increase the titer of the antibody level, yeah, as the protection of the COVID-19, yeah. So the booster or the second shot will give stronger protection, will give you the antibody level in your body much higher, yeah, to protect yourself from the COVID-19. And this is the conclusion, yeah. So the COVID-19 vaccine, it is, I derived this from the CDC, yeah, helps protect you from getting COVID-19. 2 shots, first shot and 2 shots. And also beside the vaccination, of course, the protocol must be followed strictly, yeah. You have to wear a mask and stay at least 5 feet apart, and avoid the crowd, and wash your hand with soap, yeah, to protect against the COVID-19. Okay, these are the reference that I have been used, and thank you all, yeah, for your attention. And ayo vaksinasi, jangan takut vaksinasi, ya. Yeah, we will meet directly. We hope for offline study, yeah. So vaccine yourself, yeah. Thank you, Andrea. Maybe okay.
Thank you very much, Dr. Yati Sumiati, for the amazing presentation. And now I guess we have learned even more about COVID-19, including how does the vaccine work, why should it be two shots for the vaccination, and even there was an animation about the vaccine comparison to decide which of the vaccine has the highest efficacy, which I think is extremely helpful for the participants to understand more about the topic shared. So now I believe the participants are also already able to answer whether we have won the battle or not with the COVID, right? Okay,
Yes.
so ladies and gentlemen, I'm also pretty sure that we have some questions right now before we start our discussion. Dr. Yoti Sumiati, how would you like to conduct the discussion?
Okay, just like Mr. Jody, I will start from the left one. Yeah.
All right.
Okay. The first question is, what is it? The RNA vaccine and subunit vaccine can trigger immune system, but based on data, why does RNA vaccine like Pfizer is safer and more effective than the subunit vaccine? Yeah. As mentioned before that, I have maybe you can explore in the YouTube, yeah, the video about the efficacy of the vaccine, yeah. It is actually depend on the time or when you perform the clinical trials, yeah, at the peak of the disease or not, yeah, like in GNG, Johnson and Johnson, and maybe AstraZeneca, yeah, and Sinovac also, yeah. It is the clinical trial is performed when the disease is very high, yeah. So the efficacy is quite lower than the Pfizer and the Moderna, which is use the RNA, yeah, the genetic material platform. Okay, I mean, actually the vaccination you use the mRNA, yeah, and then the subunit are using the inactivated vaccine. The most important is the protection that given by the vaccine is avoiding you from the severity of the disease, and then you don't need to experience with the hospitalization, yeah, and then uh, uh, the vaccination will end uh, the pandemic, yeah. I mean, because this vaccination will give protection when you have you must experience with the disease, you don't experience with the severe condition, yeah. Actually, the one thing you can prevent you from the disease is you follow the protocol, yeah, the health protocol. You must wear your mask, yeah, and then you wash your hands and avoid the crowded and so on. Okay, that is from the first question, I think, yeah. And then the second one is okay, Sinovac 60 to 7. It is the similar question, I think, yeah. Yeah. Even though the study, the same vaccine Sinovac in Indonesia given 65% efficacy, and then in Turkey given about more than 70% efficacy, it's because the different condition between Indonesia and the Turkey. Yeah, I think the most important is already given that vaccination will help you from the disease, avoid from getting a worse condition for the disease. Okay, I will go to the third question. Yeah, lately, news Indonesia thought that AstraZeneca vaccine is may not recommend for people below 30 years old. How about some people below 30 years old who has received the vaccine? Is there gonna be a bad reaction for the body? Okay, the AstraZeneca vaccination is quite hot, yeah, because of the, yeah, I'd like to tell you that our education staff also experienced many side effects from the AstraZeneca vaccination, yeah. Almost all educational staff experience with the headache and the fever. Yeah, one of them go to the emergency room. Yeah, okay. But we believe that in government have already stated that the AstraZeneca quite safe, yeah, except for the batch number 547 that still in there still needs further investigation, yeah. And then for AstraZeneca vaccine, if you have experience with clotting disorder, I mean with heart or stroke, yeah, or you are in medication with blood clotting, yeah, with the anticoagulant therapy such as heparin, warfarin, clopidogrel, or some of therapeutic. It is need precaution. Yeah, you have to discuss with the doctor, and then will be to get the vaccination from the AstraZeneca, because currently the distribution of the vaccine in Indonesia is AstraZeneca. So there's no option for current condition. Yeah, maybe if you don't feel don't safe enough, you can wait until Sinopharm come in distribution. Okay, the last question is about the vaccination program has been launched. There is information that spread communities that we should check the effectiveness of the vaccination through the rapid test. If there's no sign of IgG and IgM, it means that the vaccination doesn't work. Okay. Yeah, we know that the vaccination will give you a number antibody, yeah, that neutralizing antibody that will protect you from the disease, yeah. And this number is different between people. It's individual, yeah. Some people have the large number and some people does not, yeah. Actually, currently there is a test, yeah, antibody test, yeah, antibody. You can, after vaccination, after a week or 2 weeks vaccination, you can test your antibody level, yeah. There is a laboratory testing for that, yeah, that when your number is more than 10, yeah, for the titer, the vaccination means success, will help you from the COVID-19. It doesn't avoid you from the COVID-19, but when you experience with the COVID-19, your antibody is there. Your antibody will give you an advantage to clearance the viruses, and you don't experience with the severe condition from the vaccination. I think, yeah, you should go to the clinical laboratory and check your antibody levels there. There are the testing for antibody. Okay, I think that's all, Andrea.
Okay, thank you so much once again, Dr. Yati Sumiati, for answering the questions and help us understand even more about the topic shared before. So in conclusion, ladies and gentlemen, as what Dr. Yati Sumiati has reminded before, make sure you keep following the protocols given, wear your mask, and have a vaccine if you hadn't so. And now we would like to invite Goldie Bernali as the Chief Committee of International Webinar Collaboration SEMA FF-KMUP and IPSA to hand out the Certificate of Appreciation for Dr. Yati Sumiati. For Goldie. Okay, is the documentation team ready? 1, 2, 3. All right, thank you very much. And once again, I am inviting back all of the panelists to turn on the camera because we are going to take another documentation together. And I guess we have a few slides here. So it's going to take some screenshots, slide by slide. Is the documentation team ready? Slide 1 in 1, 2, 3. Slide 2, 1, 2, 3. Slide 3 and 1, 2, 3. Okay, thank you very much once again, Dr. Yati Sumiati, for your presentation. It's really, really helpful for all of us.
Thank
And
you.
And also thank you for all the panelists for taking the photo together. And now, ladies and gentlemen, let's move on to the next session. One of the most session that I believe all of the participants must have been waiting for. We're going to be having games here. So please have your device ready and join us on Kahoot. Yep, here we have our game pin. For the participants, you can enter your pin here as it shows on the screen on your device. And we are waiting for you to join. Come on, guys. Because there are going to be prizes, amazing prizes waiting for you. So we are really waiting for you to join our game. Also, I would like to remind the participants, you are required to use your full name while participating in this Kahoot game. So if your name apparently didn't fit in this space, you can just use your first name instead. You can see we have like 200 participants here and more. So there are going to be lots of participants. It's going to be really fun, guys. So I do really encourage you to join this. Remember to use your clear name. So if you apparently become the winner, our committee can contact you easily. We're still waiting for you guys. Come on. And as we are waiting for more participants to join, I will read some rules that will be applied for the participants during the playing of this game. So there will be 3 winners in total from champion 1, 2, and 3, which are going to be determined by the highest score on the leaderboard, which is going to be shown at the end of the game. So in the end of this game, you sure can see who's the winner of this game. And every single winner of this game will get email for the gift. And as it said, the prizes are Grab food vouchers, I guess. So it's gonna be really interesting. Come on, go, go, go. I can see there's still more participants who haven't joined this game. Come on, guys. Don't be afraid because the prizes are going to be really interesting and beneficial for you, especially in this pandemic. Remember to use your real name, your full name, if possible, so that our committee can contact you very shortly if you were about to become the winner. guess we are going to wait for more participants to join until about 2 minutes more. So if you haven't joined the game, please do so because we are waiting for you here. I can still see some participants keep joining this game. So I guess we're gonna wait for a little bit more. Come on, guys. There's apparently some more. Okay, it's already 11:26, so I guess we can start the game. Are you ready, guys, for this? Because the quiz is going to be related to the topics given just before in those previous two sessions. So if you put attention in those sessions, I believe that you can definitely answer these questions. Good luck, everybody. Okay, so the first question, which is the antiviral being used for COVID-19 treatment in Malaysia? There are some options right here. Can you read? Okay, more answers to come. The answer is favipiravir. Wow, there are actually wow! Congratulations, Chloe, and you can still win, guys, if you answer correctly in more questions because we apparently still have more questions to be answered. I guess we can continue to the next one. Okay, for the second question, the risk of developing blood clots is higher in a vaccinated person compared to a COVID patient. True or false? There's only two options, so I guess you can answer it as soon as possible. It's false. Okay, let's go on to the next question. Wow, you can see here. And for the third question, which is the interleukin-6 inhibitor for COVID-19 treatment in Malaysia? I think if you put attention in Mr. Jordy's presentation, you can definitely answer this one because the answer was there. More answers to come. Come on, guys. You can do this. Well, the answer is tocilizumab. And we can continue to the next question. Wow, Chloe is still winning right here. It's okay. For the other participants, you can still win if you answer correctly in the next question. So we can continue immediately. Okay, for the fourth question, which antibiotic is the drug of choice for COVID-19 category 2? There are 4 options here. And more answers to come. Oh, apparently there's no antibiotic needed. So guess who's answered correctly here? Oh, clues are barely out of this. And we have new name here. We can continue to the next question. And the fifth one, the following are the contraindication of tocilizumab except. So which are of these options, which is not the contraindication of tocilizumab? Come on, guys. Okay, so the answer is the end-stage renal failure. We can continue to the next question. Okay, here we have our sixth question. The following are the potential side effects of methylprednisolone except. So which is of this option, which isn't the potential side effects of methylprednisolone? Okay, so here's the answer. We can continue to the next one. Oh, apparently Shokin is still winning here. And this is the seventh question. What should be the dose of tocilizumab for a 60 kilograms patient of COVID category 5? Okay, so here's the answer. Wow, new names are coming. I guess it's getting more competitive, isn't it? Let's continue to the next one. Which of the following is a sign of improvement in oxygen requirement? Oh, we got another options here. The answers to come and clock keeps ticking. Let's see. Who keeps spinning and questions? Wow, apparently 4 players have reached straight until 3 questions. Awesome. And this is for the ninth question. What is the dose of enoxaparin for a 60 kilogram ESRF COVID category 5 patient with a platelet count of 15 INR of 2.1? Here we have some options you can choose on screen. Oh, there are more people who answer correctly. It's good. Let's continue to the next one. Wow, congratulations, Shoki. And this is the 10th question. What should be the usual dose and duration of favipiravir in the ESRF COVID category 4 patient with no dialysis? You can see some options right here. Okay, because there are more people who answered correctly, so I guess a lot of participants apparently put attention on both sessions before. And let's continue to the next one. Okay, here's the 11th question. A system containing a group of cells and proteins that protects our body against infection from various pathogens. There's an immune system or digestive system, respiratory system, or excretory system. Come on, guys, more prizes to come. Oh, apparently there are a lot of participants who answered correctly. This is really good. Let's proceed to the next one. Okay, here's another question. Which of the below is not a level of the body's natural defense system? Is it the barrier, or innate immunity, or herd immunity, or adaptive immunity? I guess a lot of participants will be able to answer it correctly. Let's proceed to the next one. Wow, I can feel seashell can keep swimming. It's really great. Let's continue to the next one. COVID-19 vaccine alters our DNA. Wow, a lot of participants answered correctly. Let's keep continuing to the next one. Which statement is wrong about Sierra? This is included in the second material, which Dr. Yati Somyati has presented before. So if you put attention in her presentation, I think you would be able to answer this correctly. Okay, let's see. Who keeps winning? Oh, there are some new names here. It's good. Let's continue to the next one. Which vaccines have a higher level of effectiveness compared to other vaccines? I think this is also included in the second presentation. Okay, we can see more participants answered correctly. And we can continue to the next one. Which vaccine has the advantage of being able to be stored at high temperatures? Is it Sinovac or AstraZeneca or Moderna, or is it Pfizer? You guys choose. Oh, there are actually more participants who answer false. It's okay, we can still get more correct answers in the next questions. Okay, so 1 out of 5 people will have the probability of getting sick when they encounter someone infected by the virus. What does it call? Is it body immunity, antibody, partial immunity, or is it herd immunity? Let's see. Oh, there are only a few participants who answered this correctly. It's okay, let's continue to the next one. Okay, so our body is exposed to antigen for the first time upon vaccination. What occurs to us after we get the vaccine? Will we have superpowers? Or we cannot be infected with the virus? Or does our immune system specific antibodies or our risk of developing blood clots increase? Which one you choose? Oh, there are a lot of participants who answered correctly. So I guess it was considered as easy one. Let's continue to the next one. How long is the recommended interval between the first and second dose of the Moderna vaccine? Is it 14 days, 28, 2 weeks, or 21 days? You guys choose. Let's see. Oh, apparently it's 28 days. Kind of a lot of participants did answer correctly. And I guess we're getting to the last question. Yep, I guess it is the last one. So good luck, guys, for this last one. How long should a COVID-19 survivor wait before receiving convalescent plasma therapy? Is it in 2 months, 1 month, 3 months, or 1 year? Can you receive the therapy after you survive from COVID-19? 3 months. Next, let's see. Here's the real winner of this quiz. We have the third winner, Shokin. Congratulations. The second one, we have Shai. And the winner of this quiz belongs to Stephen. Congratulations. Congratulations to all 3 winners. Our committee will contact you very shortly by email. And so just wait for the confirmation. And once again, congratulations. If you weren't the winner, it's okay. Because by these, I hope we can learn a lot of new materials through those 2 presentations by our amazing speakers. So now, ladies and gentlemen, it was a very fun ride, right? And I hope we all did have fun together during this event. And now, lastly, we would like to invite the president of IPSA, Saranya Balakrishnan, to give some remarks, please. Dear Ms. Saranya Balakrishnan, the screen is yours.
Okay, so am I audible to everyone?
Yep.
Okay, so a very good afternoon to our esteemed guest of honors, respected speakers, my fellow peers, and our dear participants. Allow me to introduce myself. My name is Saranya Balakrishnan. I'm the president of IMU Pharmacy Students Association, Malaysia for the term of 2021-2022. So this is our very first collaboration with Pancasila University, Indonesia, which we have successfully completed, and I couldn't be more proud of everyone for how this event has turned out. I would like to take this opportunity to thank our guests of honor for being here today to grace our event, our very experienced speakers for teaching us all today, all the event committee members for their tremendous effort in the preparation and execution of this collaboration, and our dear participants for taking the time to be here today. We sincerely hope that everyone found this webinar collaboration useful and now gained a much better understanding regarding COVID-19 vaccines and management. I know I definitely did. We also hope you had tons of fun with our Kahoot session, and congratulations to all our brilliant winners. Lastly, we hope your continuous support in events to come and that everyone continues to stay safe and stay protected. Together, there is nothing we can't achieve. Have a great Sunday ahead. Thank you.
Thank you very much, Ms. Saranya, for your brief remarks. And once again, ladies and gentlemen, I would like to thank all of the participants for taking your time of your busy schedule to join us on the International Webinar Collaboration SEMA FF-KMUP and IPSA today. I hope by this event we can truly learn a lot of new things, and we can also broaden our horizon, especially about how should we face COVID-19. And please always remember the things that had been reminded by our speakers before. So I, Andrea Angelica, on behalf of the Committee of International Webinar Collaboration SEMA FF-KMUP and IPSA, would also like to apologize if there were ever some mistakes happened along the way. And I hope to see you all in the next time. So before we end this, guys, can you please open your camera once again? Because we would like to take another documentation for the last time, especially for the panelists. We're going to have another photo session before really ending this event. Okay, so we're going to take slide by slide. Documentation team ready. Slide 1 in 1, 2, 3. Smile. And slide 2. In 1, 2, 3. All right, to the next slide. In 1, 2, 3. Okay, finally, thank you so much once again for every single panelist and all of the participants who have participated in the International Webinar Collaboration SEMA FF-KMUP and IPSA. And if there were some mistakes that I or the committee of this event made during this event, we are truly apologizing for that. So we hope that you can stay safe wherever you are, and please kindly follow the protocols given by our government. And we hope we can see you in another time. Thank you so much.